Good evening, everybody. I just wanted to welcome you along to our first event for 2023. My name's Roger Pryor. I'm one of the committee people. You're probably used to seeing my name at the bottom of emails that clog up your inbox. But we just thought we'd do a little bit of an introduction for this evening. Before I go on and do that, though, I wanted to acknowledge the fact that we're meeting tonight on the land of the Awabakal and Warrukmai people. And given the topic about the pandemic, I also think it's worthwhile acknowledging that one of the greatest problems faced in that first contact period in the first few years of white settlement here within Australia was the actual bringing of Western diseases or European diseases, which had a massive impact on First Nations people here in Australia, or the continent we call Australia, and also places like Hawaii and everything else, with introduced things like the common cold or influenza or smallpox here in Australia in particular. And the impact of that on traditional communities was very, very significant. I also wanted to acknowledge a little bit more happily than that today is International Women's Day, and it's fabulous to see so many women here as part of our audience and as part of our panel. We've in fact managed for once to actually achieve gender equity, and a little bit better than that. But I know that lots of people make all sorts of comments, but it's fabulous to see the fact that there is plenty of recognition of the fact that we do have an International Women's Day, and wanted to acknowledge that. I also wanted to fulfil a very important promise that we thought of when we put this event together, and that was to pay tribute to and thank all of our frontline workers. And I know we've got a few people who've registered and come along tonight who are in that category. And I also know that people say, well, you know, thanks is all very nice, but sometimes a little bit more than that would be good. But I wanted to relay a little story that relates to this. At exactly this time, pretty much the first time that the Newcastle Institute had its meeting in 2020, so 3 years ago now, it was our live meeting, and on that same day, my wife and myself were in Ireland. We were over there because my youngest daughter was born on St Patrick's Day and had decided that she wanted to spend her 30th birthday in Galway. And part of the objective, or part of the anticipated outcome, was that we would probably drink lots of Guinness together and have a pretty good time of it. In the week before that, and the week that this particular meeting was on, we were down in Cork and watching on television as Atletico Madrid played Liverpool in the European Champions League in front of an enormous crowd in Liverpool. All that day we'd been watching horse racing from Chelmsford in England, where 40 and 50,000 people were there at the race course. And suddenly on that same night, the World Health Organization declared a global pandemic. It was like watching a house of cards topple. Very quickly, the whole of Ireland shut down. Within a couple of days, we couldn't get any food to take away anywhere. We only just managed to get onto an aeroplane and out of the country. The hotel we stayed in the night before we left, which was actually on the 16th of March, so think about how close that was in that intervening time. It had just laid off half of its staff that afternoon, and we were pretty glad to get on a plane and to celebrate Katie's 30th birthday with all of our silly Irish hats and things on, sitting in the bar in Abu Dhabi. And on the way home, we got back to Sydney, and of course it was like a different world. We weren't forced into quarantine because there was about a week before that started to happen, but we were certainly in a world that was very unusual to us, where there was lots of fear, there was lots of concern, and I think that the work that Robin and some of the people did here in Newcastle, in terms of getting some of the people who are now represented to talk about what was likely to happen as the pandemic went on, was certainly important things to do. But it was a very, very different. No one was really sure what was going to happen. We didn't know what was going to happen in terms of levels of infection and transmission and all of those sorts of things. It seems, looking back now, that there was a lot of, maybe there was a lot of nervousness and panic or whatever. But at that time, all of the people who are involved in the medical profession simply had to keep going. They simply had to keep turning up to work. They couldn't afford to let any of those fears and panics get to them in too much of a way. They had to keep doing that. I want to thank all of those people, and not just the people who are the doctors and nurses and things, but all of the people who work in the entire healthcare and allied health industry, even down to people who cleaned the hospital, people who provided the food, and people who kept all of that system running at times where it must have felt like you've probably seen that cartoon about people building an aeroplane while they fly it. This was probably the opposite. It was taking all the nuts and bolts out and pulling it to bits, trying to think about how on earth you're going to get it back together again. And not only in the health profession, but in police and emergency services. I know at that stage that people thought, well, one of the biggest dangers here is if we just let everything go mad, that everybody gets caught with this particular illness. What happens if we don't have any police to keep our community safe? And we'd seen instances in other areas, not so much because of disease, but certainly because of fire and all sorts of natural disasters, the rise of things like looting. Who's going to actually keep our community safe? Who's going to make sure that we don't actually plunge into absolute lawlessness? Who's going to come and put the fire out when some idiot burns a garbage bin at the end of the street near something else? If we don't somehow manage that, and if we don't make sure that our capacity to cope has a certain element of resilience built into it, then we could have ended up in all sorts of horrible situations. And as we look back now with the benefit of hindsight, it's sometimes difficult to understand what was going on at that stage. My former background is as a teacher, and I remember thinking back at that stage, I was very, very pleased that I was no longer teaching, because the ability to move rapidly between face-to-face instruction in a very known and controlled environment, if you like, to moving to online delivery, to doing things like packaging up stuff to go home to multiple households, all of the work that had to go sort of jumping across into one box and then into another box and working out ways to deal with all of that at the same time as it was sort of expected that you basically kept it all running, because we needed that so that people could go to work or work from home and do it successfully. So teachers obviously were part of that as well. I've got a whole list of people here, but I don't think we should miss any of them out. People who worked in aged and residential care. They were sort of situations where those people had a dual concern, their own family at home, but certainly the people that they were caring for. And we all know some of the statistics that came out of places in those sorts of circumstances and the difficulties that that created. Even supermarket workers. One of the funny things that we brought back from Ireland was the fact that in the little country town we were staying in, the supermarket plague hadn't descended at that stage as it had in Australia. So we actually packed large packets of toilet paper and brought them back with us, because that was something which was almost impossible to get in Australia at the time, if you can remember back to all of those circumstances. Remember that we actually had people fighting in the aisles of supermarkets because of issues around who got there first. Think about the supermarket workers who were just turning up to do their normal day of shelf filling and then had to deal with the combined anger that was there in people having to deal with a situation that they were unsure of and unaware of. The logistical people who had to get that stuff to the supermarket shelves and stay well enough to be able to drive the trucks and do all of that. And last but not least, the people who delivered our home deliveries to us. The rise in online shopping that was absolutely enormous right throughout the global pandemic meant that we needed people to fulfill all of those sorts of roles. If you're one of those people or if you're someone else who worked through all of that and I've missed you out, then my apologies. But certainly very much from all of us here at the Newcastle Institute, and I think really quite legitimately from right throughout our society, we do, when we think back on it, really owe an enormous debt of gratitude to those who simply kept going, who simply realised that communities can only operate when those who can are able to fulfil the sorts of roles and tasks that help keep everybody else safe and managing to get on with things. And hopefully we're through and looking at a different world, but I hope that we can also remember some of those sorts of lessons and think about the value of communities and of sharing and of acknowledging the work that each of us does in making that happen. So thanks for being here tonight. I'm going to get Robin to come and continue now that we've got those formalities out of place. But could we please just give a round of applause to all the people who made things like that happen? Thank you.
Thanks everyone. It's my pleasure to introduce the panel tonight, and so I'll do that not in any particular order, and I'll point them out as we go. Craig Dalton, who was just sitting there, and some of you may recognise Craig from the Zoom meeting we had in April 2020 when we talked about the pandemic, also with Peter Saul and Tanya Davis. So Craig's a public health physician with a Masters in Clinical Epidemiology from the University of Newcastle and a graduate of the Centre for Disease Control Epidemic Intelligence Service in Atlanta in the States. He's the founder of Flu Tracking Net. .net. Some of you may be familiar with flu tracking. It's one of the largest online participatory surveillance systems in the world, with over 150,000 Australians reporting their flu-like symptoms every week in winter across Australia and New Zealand for normal flu seasons, but also through the COVID pandemic. Is that right, Craig? Yep. He won Australia's Data Innovation for the award for flu tracking. One of the things I noticed in his comments is that he was cited by Dr. Anthony Fauci at the US White House COVID-19 task force briefing, and there's actually the time that was cited as the basis for the US community control guidelines for COVID-19. So Craig has a number of other bows on his string. But remarkably in that strings on his bow. I'm not nervous. So in the very first meeting we had on the pandemic, Craig has made some remarkable predictions about what would happen. I mean, he's an epidemiologist, so it was probably likely that was to be true. One of my take-home messages was the wave concept, which I should know because I have done epidemiology, but it sort of hadn't worked in it for a while. But the concept of waves and the way they keep coming and the way the virus changes and everything like that, it's sort of every time there was a wave I announced, I thought, oh, Craig's predicted this accurately. So we welcome Craig here tonight. The next person on that far end is Helen Logan, Dr. Helen Logan, who's an adjunct senior lecturer in education at Charles Sturt University. Her work has been published in peer-reviewed international journals and other professional publications. She's recently the author of 2 articles related to the pandemic, including responses to coronavirus pandemic for early childhood services across 5 countries in the Asia Pacific, which is really interesting to read. And for those people who've had contact with early childhood through the pandemic, they have been amazing. Our next panellist is Dr. Professor Francesco Paolucci, just here, who is Professor in Health Economics at the Business School at the University of Newcastle and also at the School of Economics, Management and Statistics at the University of Bologna in Italy. Francesco is a scholar and advisor. Over the last decade has been extensively published in the areas of public policy, economics and management, with a particular focus on healthcare nationally and internationally. Professor Paolucci is a permanent member of the Risk Adjustment Network, which is the leading network in health insurance and financial research and advisory globally, and a country representative for Australia. So a very accomplished person in health economics. We deliberately wanted to have people from different settings to this night because different settings have had different approaches and different outcomes in the pandemic. Viv Allinson in the middle. Many of you may know the multimedia star, Viv Allinson, who's CEO of Maroba, and those people who have had contact with Maroba, you know what an outstanding organisation this is, and Viv has been on the drum frequently and calls it like it is, I think, and it's such a refreshing thing. Viv never accepts the status quo. For 3 years running, she was announced as the Australian Game Changer of the Year and Visionary CEO of the Year in her role as CEO of Maroba. She's a leader who strives to bring others on the journey of growth and change, always sharing generously her time and experiences to support others who aspire to be a difference maker. Most recently, Viv was the recipient of the 2022 Hunter Business President's Award for her courageous advocacy for older Australians. The challenges faced by aged care through this pandemic are enormous, And I have to acknowledge before introducing our final speaker that those challenges are ongoing. We acknowledge that the pandemic is ongoing. Our last panellist, second from the far end, is Dr. Fiona van Leeuwen. Many of you might recognise Fiona from her media work as well throughout the pandemic. She was the principal GP and owner-director of Hamilton Doctors up until 2018, and she continues to work in that area. She's the chair of the Clinical Council of the local primary health network, Hunter New England Central Coast Primary Health Network, and that's been since 2020. She's chair of the Hunter General Practitioners Association, or was chair previously, and she's also on the RACGP, the Royal Australian College of General Practice, as the Hunter representative. There are a lot more other things that Fiona represents, but some of those may come out later. But she completed her medical degree here in Newcastle some years ago. So as I said, we want viewpoints from a range of the experts we have luckily to have gathered here tonight. And we do acknowledge that that pandemic is ongoing. New South Wales close to I think a rolling average of about 1,000 cases a day, and the case numbers have been increasing, which probably no one knows about because it never gets reported unless you look at it. And there's other data that I'm sure will come up. One of the things that I looked at was, I think that in the last week in February there were 45 outbreaks in aged care facilities in New South Wales. So it's that sort of thing that you think this is happening and so many people are pretending that it's not. I think these data are indicative, but they belie the impact of those cases, not only in aged care, those cases and many deaths that have happened and still happening on the families and loved ones impacted by them, on the economy, on the current and potential workforce, and the willingness of people to work in particular the sectors. So I think we have to recognise that those problems are not just focused on individual but community at large. So I wanted to ask first, and Craig, I'll direct this to you. Did the pandemic progress as predicted or expected? And where it didn't, why, how did it vary?
Do you mean biologically, from the perspective, or the human factors?
No, the epidemiology of it.
Yeah, I mean, I guess based on basic transmission principles, yes, it did. So basically it came in, it hit a lot of people. Everyone was susceptible at first. People went to ground, so the number of susceptibles and contact rates decreased. So it peaked and then it dropped. We didn't ever burn out really all the susceptibles because people basically reduced their contact. So that sort of really is what ended the peaks mostly, all the controls in place. I think what we hadn't imagined, when I presented last time, we had sort of peaks like this, and we were thinking that was where it came back perhaps seasonally, and new people who were non-immune got infected. What we didn't count on so much was such a rapid change in the variants, so allowing people who were previously infected to get infected again. And so that wasn't predicted. That was a bit of a surprise. Yeah, a nice unexpected surprise was that it got milder and has remained milder with the Omicron variant.
And is that expected to continue, that as the variants occur, that they are likely to be milder, or is that too hard to predict?
I think it's too hard to predict. The black swan event would be that we get another variant that is... Remember, the Omicron variant, which we've got now, which we're calling mild, is if you're unvaccinated. And I was at an outbreak in France last year and saw a lot of unvaccinated people at a meditation retreat get hit. And it's only a quarter as severe, but a quarter as severe as, unprotected SARS is pretty damn severe still, So if we get something that comes through that's completely immune evasive, that all our past infection, past vaccination has no effect, and it's as infectious as Omicron, which means we probably can't control it, well, that would be a disaster. We hope it doesn't happen. continuing to have a mild, rapidly transmissible virus. Rapidly transmissible meaning we're getting topped up with exposure and little boosts in immunity mostly. That's kind of a nice sweet spot at the moment.
Okay, thank you. We might move on now to some comparisons with other countries and with other similar countries. I might start with you, Francesco. So how do Australia's, and I suppose you'd be looking at the health economics of it, health economic and other strategies and outcomes compare to other similar countries?
That's an interesting question. I suppose that Australia is quite unique if you look at its geography, also the density of people. And when we were hearing the story before, actually when the first outbreaks hit Europe, I was actually just arriving on the 21st of February in Milan. And on the 22nd, we declared, or Italy declared, patient 1, who some of you might know, because that's when the world started thinking, okay, if Milan is in danger, and that's one of the richest region, arguably in Europe, in the world, with one of the best healthcare system, well, we were in trouble. So I think that is interesting to ask a question around comparisons. Because Italy was clearly unprepared. I think most countries would have been at that point if that, let's say, if it hit them in the same way. Now, the reality of Australia is it offers a lot of advantages on how you can, in essence, delay and respond to something like COVID. Europe obviously had more fragilities. If you look at not only the density of people, but also the proximity between young and elderly in the population. So if you look at the Milan region, unlike regions that are still in the north, very productive, wealthy, and so on, the disastrous scenes that we have experienced would have been infinitely more disastrous if you had them in Rome or in Naples, where you have a family composition that it's really, truly intergenerational, and incredible density in how people live in all socioeconomics. Clearly, socioeconomic plays a huge factor in that regard. But in particular in the Bergamo region, which is an extremely, well-off, productive, with an elderly population, that was the most catastrophic event that you could have possibly imagined. I still remember the army going there, bringing out coffins, and it was like tragic for many weeks, in fact. Now, so if you take that factor into account, so the geography of different countries, of course, countries like Australia had an important advantage, right? But also equally other countries, in the UK is clearly the natural example, which has natural barriers, suffered severe outbreaks. And that was also related to what Craig was saying before. So what do you do when you reach the peak? Do you speak about herd immunity, or you actually put on restrictions? And that is the second element. So Australia had, I think, a very strong regulatory response. And that was, in my view, and I think in many of the views that we documented in the two special issues that we edited on COVID, covering over 25 countries, it was, in fact, ex post, but also in that particular moment in time, a very pragmatic approach. Now, if you look at the policies thereafter, so when vaccinations were introduced, that's a separate conversation.
Yeah. Okay, thank you. Helen, you've published recently also on this, the comparisons. I wonder if you wanted to make some comments about the early childhood sector and comparisons with other countries.
I really would, Robin. So during the pandemic, I was working with colleagues in China, Thailand, South Korea and Japan. And what was interesting there was that their response rate was so quick. So, for example, in South Korea, they implemented all sorts of tracking of the population via their smartphones, CCTV cameras, credit cards, and other facial recognition technology. Thailand was very similar. Japan was a little bit different in that they offered guidelines to their community, but the Japanese population as a whole were very compliant in following the government measures, and it was some months later that they declared a state of emergency. But so all of this was interesting, but getting back to the early childhood education and care sector, the emphasis very much there was on maintaining parental workforce participation. So the children's learning was important, but what was really important was keeping the workforce going. And so the early childhood educators became essential workers overnight, but with no experience of a pandemic. They didn't know what to expect. It was the same in China, Japan, Thailand and South Korea, all about keeping the workforce going during those times. Another thing that was really quite interesting in terms of slowing the pandemic in those countries, or that came out of my research, was differences in cultural practices that I found particularly interesting. So mask wearing was very common in a lot of the Asian countries, but even though Australia is a multicultural country, mask wearing wasn't as commonplace. And other aspects too of the way we would interact with children, families in our society. So in Thailand, for example, those social etiquettes of cultural greetings where Thai people would often place the palms of their hands together and bow their heads slightly was very helpful, because there was no handshaking, there was no hugging. And so from that perspective, it's very different from the medical perspective, I know, but that was a helpful at that time.
Thank you. I just wonder if anyone else has got any comments or would you about the comparisons across countries. Yep.
And I'll speak from the perspective of hearing from our then Prime Minister, who seemed to use the comparisons with other countries as the get out of jail card. And he kept saying, oh, but we're doing better than this one and we're doing better than that one, instead of taking responsibility of how we were really doing. And he should have been revealing more of what was really going on. So I found the comparisons offensive coming from our national leader. And I think he just sold out the whole health system by using those comparisons and as an excuse for how we were performing in those spots where we were performing very badly.
I told you she tells it like it is.
I guess I was just thinking, reflecting about this before this evening, and thinking that in actual fact, and I really enjoyed your comments earlier about Europe, and that our geography has saved us, because I do agree also. Had this happened to us in the same way that it happened to the Italians, we would have been in that state. I have no doubt about that whatsoever. But I don't think that really the Australian population has kind of grasped that was the way, because we were saved by our geography. We were saved by being able to watch this pandemic come down and learn from what people were doing in other places, and then enact our systems in a really sort of a slower and an informed way. I was thinking about this fantastic book that I read years ago called On the Beach. Has anybody ever read that? Yeah, because actually I'll have to say, in the beginning of the pandemic, for a lot of the GPs around, everybody was trying to work out what the mechanisms of transmission were. And we were all doing that too while we were continuing to work. But everybody was trying to work out, was it droplet, was it airborne, and some of the GPs were saying it's definitely airborne, when all these papers are coming out saying it's not airborne. Of course it is airborne in the end. And there was a lot of fear, because I felt like we were on the beach. And anyway, I think that I agree. I think that the comfort we gained from the geography and being able to put in those systems has saved us.
I might just, Craig, did you want to say anything about comparisons?
I'm looking something up here just to check, so I'll be careful. I think one statistic that's interesting, Lombardy, which was the epicenter, is a very rich place, and they have on average at least 3 to 4 times the number of ICU beds per head of population to what many places in Australia have. And they were refusing admission, I think, above 40 years of age at one point to their ICU beds. So you can imagine what would have happened if we'd got that in Australia. Yeah. And if you talk about rural towns and rural areas, much lower rates of ICU bed capacity. So.
Thank you. I want to ask each of the panellists to comment on what the most significant challenges were in terms of their setting for managing the pandemic, and I'm sure they'll also cover what the factors were that contributed to those, whether they were policy factors or other factors. Science denial was a significant challenge throughout the community, the politicisation, the preparedness, not only in terms of the pandemic in the past, but also the challenges that you're currently facing. So Viv, you might want to start with that one.
Sure. Well, as you know, aged care faced many challenges, and a lot of them were based on very poor decision making at the top, which then flowed down through our local health district. Very early in the piece, when we were preparing for those first cases in our aged care service and in the Hunter, we were sent a memo by the Area Health Service to say, do not send your positive cases to us. Now, how do you feel about that? So I wasn't taking that lying down. I contacted some key contacts in the health service, and we had that overturned really quickly because everybody else accepted that that was okay, was never going to be okay. And it was only about, once we got organised, if we could get our first couple of cases into hospital, get organised back at the camp, and then be able to take them back and then manage the rest coming through. Now, fortunately, I didn't need to send anybody to the hospital, but that was an incredible challenge. The other big challenge was in our service, we'd signed up to the World Health Organisation zero tolerance for infectious disease and outbreaks. I hadn't had an infection at Maroba for 5 years. But then the supply chain got broken, and they said, oh, you can only order your normal PPE supplies. Wait a minute, I hadn't had an outbreak. So I hadn't been ordering anything other than really gloves for years. And so I immediately got cut off from getting PPE supplies. So my friends in the health service were saying, Viv, we'll bring them over in the company ute if we have to help you. But again, those big decisions were being made by suppliers, that would be their measure of how you could order PPE. Then people were wondering, why can't they take visitors into aged care? Why are they locking everybody out? In those early days, no one had enough PPE, and we knew if we got an infection, we'd lose all the staff, we'd lose residents, and the whole system would completely collapse. So we had to wait till there was that government supply of PPE into our facilities to have the confidence to know, okay, it's safe to take visitors now, it's safe to open up, and that took a long time to get to happen, and there was a lot of hustling. And as you saw what played out in Victoria, in Sydney, and Newmarch and Baptist, it was horrendous. And yet we were forced, just open your doors and let everybody in with no backup or support. It was shocking.
Fiona, do you want to talk about the challenges faced by general practice?
Yeah, that'd be great. How long have we got? Well, the thing is, I mean, all of us are familiar with general practice. It's an extraordinarily busy place. It's, staffed with a whole bunch of GPs, hopefully a whole bunch of practice nurses, and then the frontline staff as well. So all of those staff, and you were thanking frontline staff, I'll have to say the reception staff in, everywhere, but in general practice, they're the ones that cop all kinds of struggles and difficulties and, harassment and quite often abuse actually as well. And they were absolutely remarkable at helping us to keep keep it going. So what were the challenges? Goodness me, there's so many. Infection control, when we didn't quite know how it was transmitted, was a problem. We couldn't get enough PPE either. We couldn't get hold of it in big enough quantities. We were trying to work out what kinds of masks to wear. Should we wear the P2? Should we wear the ordinary masks? Did we need to do fit testing? There was no fit testing available for GPs. Or nursing homes, yeah. We, as the pandemic rolled on, we needed to do vaccinations, but we had all our own work. So basically what happened to general practice is we had to do all of our normal general practice, and then we had COVID on top. So I'll have to say that I think, the general practices around the place, and it was excruciating at the time because most of the media was focusing on hospital. So everything you saw on TV was about the emergency department and people in intensive care and all that kind of stuff. But in general practice, it was absolutely frantic. We were trying to work out ways to ensure that we'd have safe patient flow so we wouldn't be infecting vulnerable people, from someone else. People were trying to get educated themselves, but, would come in with very minor symptoms and still not really think that it could have been COVID. There was extreme rapid change of guidelines, and we rely heavily in general practice on guidelines to help us, and that would be across the board. So it was from infection control, what category level we'd be at in terms of what PPE we needed to be using. That'd be on the immunisation guidelines. That'd be on how we'd be managing patients who were COVID positive. Then we had to work out how to manage the COVID positive results all coming to us in our inboxes when the patients weren't in front of us. So we changed from having public health managing COVID positive patients for quite some time, and then we all knew that that was going to come over to us because there was no way they could continue that as the pandemic numbers rose. So then we're all a bit anxious about it coming to us. How will we manage that on top of everything else? Fortunately, which was really bad for chronic disease management, but a whole bunch of people just never came to the GP. So now we're trying to catch up on all of that routine stuff, diabetes management, mammogram, cervical screening tests, skin checks, all that stuff that actually keeps our population well and at home. So and that was just a fortunate consequence of people being too frightened to come to the doctor. It was almost like if you go to the doctor, you're going to get COVID. So, we were consulting with people in the car park. I saw a little boy one time, it was absolutely pouring with rain. I was in the car park in the back. I had all my PPE on, like a mask and the whole outfit and my gloves and all that. And it was pouring with rain. And he was in the back seat. He was about 6 years old. I climbed to the back seat. He must have thought I was an alien or something, poor guy. And I just wanted to look in his ears and in his throat, So then people all around the place were getting, makeshift shelters in the backs of the car parks, etc., that we could try and see people in. Lots of people were trying different flows. We were all deciding to wear different clothes and how to manage our clothing, how we wash our clothing and get in and out of our clothing before work, coming home from work, because we were worried about taking COVID home. People were anxious, especially if they were immune compromised, to be exposed to themselves in the workplace. Then there was also the difficulties with the staffing. Actually getting workforce was really hard. So somebody would have symptoms and then they'd have to go home, and then we were also worried we'd get a COVID case and that actually the whole practice would be shut. So that was a really big worry all the time, constantly. So we'd do things like having, the hand sanitizer at the back door, and then, and I continue to squirt sanitizer on people whenever I get the chance, and on me, and we all have a bit of a squirt, and then we're all fine. People were trying to, because we couldn't get our own PPE. I remember one of the GPs was, talking to someone in England, and they thought we should wear this whole great big scuba diving kind of mask thing that had like a snorkel out the top, that kind of thing. So there was all this stuff going on. There was a lot of fear and a lot of anxiety and a lot of uncertainty because there was so many unknowns. And lots of different things were popping up that we hadn't dealt with before. I had a fellow who requires 24-hour care at home, does really well, immobile in a wheelchair, got a bit of a sniffle, could have been COVID, and nobody will come to care for him. So absolutely terrifying, because the carers who were working for private agencies, etc., didn't have a policy, or they didn't know how to do it, so they didn't go, and then they'd ring up and say, what are we going to do? He's in bed, I can't get him out, hurrah. So I think the breadth and width of struggles and difficulties and pivoting required by the frontline services all over the place they're astronomical, and in a way they're a testament to people's resilience and ability, to move with change. Never before we'd had the speeding up of medical information being shared and available to more and more people, because we've slowly been getting used to that internet kind of stuff. But never before were we so overtaken by the speed of the evolution of something, where I recall a fellow came to sit in my room at work, and he said, I'm here for this vaccine, because it was all pretty prescriptive in the beginning, really, this was what you had to do. And I said, oh, no, you're not eligible for that. That starts for you next month or something. And he said, no, it's on the TV, just so I was in the waiting room. So actually it was really true. Like, things were coming out on the media prior to us getting any formal notification, So that was really difficult. And I guess there was a lot of information coming to us from the RACGP and from New South Wales Health and from other places. One of the other difficulties was that I think this really highlighted the difficulties of trying to provide health to a nation when you have federal government and state government. You have a division of who funds what. So, very obviously we want people to be well in the community, and then it costs less in hospital, right, because they go less off and that kind of stuff. But as long as you've got people who are funded by state governments in the hospital system, and then everyone else is funded by the federal government, then you're set up to fail, really, because you're not having this seamless kind of transfer of people around everywhere. Anyway, I'm raving now, but there's plenty more to talk about, but I hope that's a taster for you.
Thank you. Helen, you mentioned one of the challenges, some of the challenges. I just wondered if you want to mention the comment you made to me earlier about women being the...
Oh, yes. Well, it is interesting that it's International Women's Day. Is that what you're meaning, Robin?
Yeah.
Yes, because in terms of the early childhood and education workforce, they are 97% women. So I'll just talk briefly about some of the challenges for that sector. For teachers generally, the workload was absolutely untenable. If you can imagine every level of a teacher's work, so for example in the early childhood sector, the staff there, the teachers and the educators were working, so the hygiene practices were astronomical. The concerns of parents were incredible. Many parents kept their children at home because they were so fearful. What that meant was then that the services were not necessarily viable. People lost their jobs. These sort of things were incredible, but also putting everything online was another huge task in itself. Not only were the early childhood educators working there, supporting the children of the frontline workers on a daily basis, they weren't supplied any PPE. They bought their own masks whenever they could get them. They couldn't always get them. They provided their own hand sanitizer. Those sort of things were really absolutely disgraceful. And there was a huge lack of resources. So not only were they working during the day, but they were going home at night and devising activities and programs to put online for those children that were still at home that were part of their service. So the support they gave was absolutely incredible. They really stepped up. And in terms of the economic support that was provided to the sector, the Australian government provided $1.6 billion, which was very helpful, and the JobKeeper payments were very, very helpful in helping a lot of services stay viable. The private sector, in terms of services, was really affected. But the problem with that funding was that it wasn't able to be applied uniformly. So you had to be an approved worker to get the funding. And many of the casual staff didn't get any funding at all. So they lost their jobs straight away. And if you know anything about that sector prior to school sector for all young children, and there are 1.4 million children in Australia that are serviced by that sector, you'll know that casual staff are absolutely vital to the running of the service because they cover all the breaks and they help out in so many ways. So that was incredibly challenging. Educator wellbeing was definitely impacted. There was the feeling of their own physical risk, the fear and anxiety, the financial stress. And one aspect that I found really sad was that many educators told me in interviews that I conducted that they felt feelings of betrayal because there was so much support for the health sector, and that was extremely important. I'm not denying that in any way. But these educators that were there as essential workers and some of the other allied professions as essential workers got virtually no recognition. And that was really terrible.
Thank you. Craig, I know one of the challenges, you had to spend some time in Victoria trying to support them. Is that a particular challenges, or are there other challenges that were faced that you haven't already mentioned?
Yeah, Victoria was interesting. It was a it was a kind of warning of what was going to happen to New South Wales if COVID got into our western suburbs and lower SES areas, and you could just see it happening. And I think what was interesting to see was the first, onslaught of COVID off the Ruby Princess. These are kind of middle-class people who went home to two-bedroom units, and they had very few contacts. That was kind of, we didn't realise how easy we had it in that contact tracing, in a way. And then when it got into large multifamily generation, it was very, very hard, and particularly if there were culturally, linguistically diverse groups. And it became very clear that we're applying, in some ways, a middle-class solution to what wasn't a middle-class problem with Delta. It spread through the prisons, spread through social housing, and it was very hard. I think the challenge we had was we wanted, when we were going for elimination, we tried to stop every case and identify every contact. So we would have a meeting on every case, identify 20 or 30 contacts, and then the contact tracing team, a group of 20 people, would start ringing and telling them their contacts, stay at home, get police to chase them down, find them any way they could. And we just couldn't give up at that point. We're just, we're thinking about Newcastle and trying to keep it out and control it. No one would go home. And it was very often people there well after midnight and doing whatever they could. And the challenges we had was so much information coming in. The public health controller of the day, which is usually Dave Durheim, who you'll know well, who came very close to blowing the bridge up. That position was getting, and by the way, I'm not here speaking on behalf of New England Health. Not allowed to do that. But I could be talking about any public health controllers. I worked in 2 different states. But those positions were getting 400 emails per day and maybe 40 to 50 phone calls a day. And they might be, having a chief health officer trying to call them while the chief health officer's deputy chief health officer is ringing them saying, the chief health officer is trying to call you now. And there's this constant bottleneck of information at many levels through the system. But one of the big challenges was, I think, imagination. We had to try and imagine, like the idea of a drive-through clinic. It happened everyone was talking, we need to do this, but it was considered impossible. Then they did it in Britain, everyone said, okay, we can do that. So there were many breakthroughs like that. Someone would break the mould, people would follow, but we were doing things like tracking down people through their bank records, their Google, asking them to look at their Google timeline to see where they'd been, using CCTV to track people through a building, coming through our computer to watch CCTV of different leagues, clubs, and what people were doing there and who they spoke to. Very unusual time. I'll stop there. Oh, this is one time we had a Mexican restaurant that had well, they were contacts, and I was trying to ring them over several hours, couldn't make contact, and again I'd ring and they wouldn't answer the phone, they're busy. So I thought, they're going to shut soon and we're not going to contact them. So I made this order, and about 15 minutes later basically said, I don't really want a burrito, but it's the only way I can contact you, please call this number. 15 minutes later, this very sceptical voice came and said, did you, I said, yeah. Anyway, so it worked, but there were many interesting things done like that throughout the pandemic.
Did you get the burrito?
They said they'd refund the cost, and I ordered vegetarian. I didn't want an animal killed to get the message through.
Okay, we might just move on now to looking to the sort of the rest of this current pandemic and the future, and wanted to know how we're placed to manage the rest of this pandemic, and also, God forbid, future pandemics, which I shouldn't say God forbid because it's likely that it will happen. So, Francesco, how do you think we're placed to manage the rest and or future pandemics?
Yes, well, look, I think if you look at the issues from let's say a purely economic standpoint, and by economics I mean in terms of how people make decisions at all levels, the challenges that we have faced and we've seen are classic challenges of events that are pandemics, wars, where really individuals start developing a taste for dichotomic reasoning, white or black, 0 or 1. Now, that is a major risk, and we see the signs of it, and some are very severe in terms of, you can even look around the world, the results of elections, how positioning of politicians is becoming towards some issues, and that, of course, interests many sectors of society. So if you think of one more concrete example, one thing that worries us is certainly the rise of polarization in hesitancy towards vaccine and millions of other things that might certainly jeopardize the way in which we can actually respond and have effective and cost-effective responses to future pandemics. Now, if you think about vaccine fatigue, which is now a common sort of jargon discussed around the world in certain circles, obviously you have to reconcile that with the idea of the reality of COVID. It's not like the flu. It doesn't have the same seasonality. So how do you actually get individuals to continue go and get boosters? Now, I'm not sure how many people have got more than 3 here. I'm gonna go for number 5. And if you run a survey in this room, people say, maybe you're overly cautious, or maybe there are risks you haven't calculated well enough. So those discussions are never gonna really end. The problem is how they're gonna be used to perhaps even be polarized. And this is what you're really starting to observe. I mean, vaccination numbers, depending on what communities you look at, what countries you look at, and if you match them, of course, with how the politics of or the politicization of these things is actually panning out, they are in some cases in decline. Again, Europe is a great example, sometimes also to predict some future or some possibilities. People don't want to talk about COVID. Vaccine is not even in their minds, and of course, winter is almost over. But the numbers are up there. So that is probably one of the things that concern me most going forward, because I don't feel we are particularly out of this problem. I don't think it's going to be the last issue that we face in terms of infectious diseases. And probably if we hear science, the frequency of these events is likely to increase. And largely, I think there has been a very quick, very rational, if you like, and human, if you want, sense of let's move on and forget and not learn as much as we could have. And I leave this comment with one consideration. Actually, Fiona made a beautiful comment that I hope that she was gonna continue making when she was discussing about the foundation of the Australian system. The geography certainly helped us. Our federal, state, private, sometimes very absent private, in particular in the first phases of the pandemic, leaves me even more worried going forward, because we haven't really discussed, not even during the elections, what we are gonna do to deal with this multi-level funding provision, very confusing for the patients and for the providers. And I think the recent choices of government to really go out there and look at Medicare and the reports that we're reading are a little bit unsurprising and a little bit, I would say, unsatisfactory. So we have bigger problems than we are currently seemingly thinking about that have to do with how we can actually equip our healthcare system, support our doctors, nurses, and professionals, and the aged care sector. And I think it's the other point by Craig. We really do not have enough of many things to actually face not only pandemics, but a lot of healthcare challenges. I leave it at that, on a good note.
Well, in terms of our being well placed to manage, well, we haven't yet been well placed. We're still badly placed, and it's just getting worse, particularly in terms of mixed messaging and removal of all mandates. Now, the government says, oh, everybody's an adult, we don't want to mandate and tell them what to do, which is French for we don't want to pay them to be off work. And that creates a really difficult situation for aged care and for the health system. And I think the health system is past being on its knees and is on its belly. And in terms of aged care, the workforce crisis as we go forward is just getting worse. My workers on $23 an hour cannot afford to stay in the sector. They're better off going to Coles, they're better off going to disability services, they're better off going and sweeping car parks than stay in aged care. There's 25,000 vacancies nationally. That is going to increase in the next 10 years to 45,000 vacancies, and there still is no solution to that. And yet we see, in terms of workforce generally across the nation, you cannot get workers. You can't get a barista, you can't get a vigneron, you can't get this, you can't get that. And people are saying, well, no, I want not lifestyle. I want a big pay packet and I want a career. Even to the point where people in culture, the old human resources people, are saying, oh no, I can do my job from home. How do you connect with people? What worries me is that we're creating a generation of workforce that has lost its humanity, because we know that service to others in our professions, all of us, service to others is what makes a difference to a society and a community and a health service. And yet we have a workforce now that wants to do it all from home, all about them, all about their lifestyle, no connection with humanity. And what was the big thing that happened in COVID? People lost connection. Now that's being promoted and people are being paid more to stay disconnected. Now, as a society, we need to challenge that narrative. We need, and for employers, instead of saying, oh, okay, how much do you want? Yeah, okay, we'll take you. You can stay at home all day, all night. That'll be okay, well, whatever you can give us for more money. No, we need to challenge that narrative, get people back onto front line, whatever their service is, because we know your barista can make a difference to an older person, can make a difference to a person with disability by the way they show up. They can't do that from their lounge room while they've got their feet up, patting the dog, pretending they're being on a computer and thinking they're making connections with the world. We have to change the narrative, because our society is being broken more and more every day because those things are happening. And as an ageing single woman, I know I'm going to need care one day. And I fear for the future because of what's happening in workforce generally and what's happening in the aged care sector, because nobody cares enough to fix it.
Viv for PM.
What did you say?
Viv for PM.
Oh.
Look, I think that some of the health problems we have in health in particular, preceded the pandemic. Just out of interest, and I'm sure you all know this already, but not 20 years ago or something, 50 or 60% of medical graduates wanted to be GP, and more recently, of course, it's 14%. So just by the way, there's just not going to be enough GPs. We've had this marvellous model for a really long time where you basically have your own physician, your own attendant physician to look after all your health needs. I mean, it's amazing How amazing is that? I think it's incredible, really. But, you know, so the things that existed before that you're talking about with aged care, etc., you know, same in general practice care. We have the same problem. We need general practice nurses because they're astounding, they're amazing, do all kinds of marvellous things. If I had 5 general practice nurses to work with me, I could see 5 times as many patients. Honestly, I wouldn't do 3/4 of the work that I do every day, which is administrative, time-wasting red tape. It de-skills me, it de-skills everyone I work with. You don't need me doing that stuff. You need me doing other stuff. I need to be popping into a room and going, double that dose, start this, do this test with every person that I see. I could do that. That would be fun and interesting. Certainly be really interesting. And I think what a lot of people are looking for, certainly in general practice, is we want to be, to just have a regular life. We'd like to have some, you know, education included in the job. You know, you might go to a conference every now and again. Basically not that different to the people who work in the public health facilities, you know. So we don't have access to that stuff. There's an enormous divide. Just trying not to bore you to death with quotes and things, but, you know, Albert Einstein said, we cannot solve our problems with the same thinking we used when we created them. So I think we need to change our thinking, and we need to be willing, and some people need to be extraordinarily brave, and they have to be politicians, because we have to change things. It needs to be a radical change. We need it to happen quite quickly. And actually what the pandemic has taught us is that we can do that as human beings. If we think it's truly the right thing to do and it will make a difference for generations to come in our society, then these things are the right things to do. This change is timely. You know, one of my really wise friends said the other day, you know, there's 3 human rights that should not be politicised. And that's health, education and housing. And the politicisation of health always, and certainly also in this pandemic, has been extremely damaging, extraordinarily short-sighted and very disappointing.
I agree, and I just made this note. Politics trumps humanity and economics trumps the health of the nation.
I have to speak in defense of economics once again. Yeah. No, I think these are important comments, and I think though we have to also be conscious and prepared to what these things in fact mean. So, and maybe I formulating some questions, like the problems of doctor scarcity in this country in particular compared to other countries is largely an issue of barriers of entry to actually be a doctor. I mean, and there are ethical dilemmas. Should we import more? Why don't we get more European doctors? Are they less trained than Commonwealth doctors, right? Which, you know, it's one question you might arguably ask. So the prices of medical care in Australia are among the highest in the world. In some specialties, reach 6 times more the price of other countries. Now, these are all signs of monopolies, right? So are we willing to open these sectors up? This is a fairly, and I'm going to be very pragmatic, unionized workforce, right? The AMA is not a union, but in fact it is. It has a lot of power. And clearly when we want to leave that to politics, you know, one option could be, and this is going to be a big challenge, let's go Dutch. You know, the Dutch have the same problem. They privatized everything. Do we want to go that way? Or do you want to leave it to the public and then to the politics of it? These are very big questions. I don't have the answers. I mean, I have my ideas, and I write about them. But these are very critical aspects, right? So another element. Often you come up with an idea. Look, there is actually here in Newcastle, Honeysuckle Health. Big fan. It's a company that does data analytics in healthcare. It's funded by Cigna, large insurance company, the largest in the world after Aetna, you know, falling off a cliff, and NIB, which is a local insurer. What they did, basically, they took on a mission, becoming a purchaser for insurers. So now consumers can go directly to them, and they find the best package, they find the best service. Are we ready for this change? Is the supply side, our physicians, ready for this? Are they equipped to actually play that game? These are very, very big questions, and I don't have an answer, but it's important to really start breaking the issues down to this level. I personally feel that we are ready, at least intellectually, to have that frank debate without the politics. I'm not going to give it away. Yes.
In rural areas of Australia, it's been extraordinarily difficult to get access, for example, to a specialist for a really long time. I have a good friend who works in Armidale as a GP. They've just lost 13 GPs. There are 9,000 people in Armidale and many more thousands in surrounding towns who rely on those GPs in Armidale to be their GP. So there are 9,000 patients who have no GP in Armidale at this moment. They haven't got enough staff in their ED. They don't have an ENT, for example, an ear, nose and throat specialist to visit Armidale. Newcastle now, so the urban areas are now starting to feel the consequences of inadequate service, I guess, by our community or whoever's providing enough service of specialists. In Newcastle now, we can't refer anybody to a local psychiatrist. There are none available with their books open. So we're referring people to Sydney. I've had a couple of people tell me how much they have to pay to see a psychiatrist in Sydney, and quite often it's $600 to $900 for the first consultation, which is entirely prohibitive, let alone if you have a significant mental health illness that's going to interfere with your ability to work. So the health crisis is real, and I guess you hear crisis too often and you start to think it's not real. But these things are devastating, happening so fast. Something needs to change.
Well, these are hard acts to follow and lots of really important issues there, but I really have to get a word in for education. The pandemic shone a light on the digital divide, and it's very real. So not encouraging people necessarily to be staying home online, Viv, all the time, but in terms of education, inequality to access of digital devices. And not only that, parents' knowledge of technology and how parents actually are able to access resources that support children's learning is also key. And also the capacity to access those online resources. The effectiveness of internet connectivity. So there were people that didn't have access to laptops, iPads, any form of computers at all during the pandemic. How do you engage in online learning if you don't have access to those devices? And not only that, it's also about the patchiness of our internet connectivity. And I know that would have been an incredible problem for the healthcare sector as well. But people in regional and remote areas really had problems in terms of the connectivity. So a couple of my final points would be we need to fix the digital divide. It's really a form of inequality, great inequality. It's quite hidden in many respects. Individual teachers and educators were outstanding in the pandemic right across the education sector. Teaching is difficult. Parents know that now, especially if they've had first-hand knowledge of online lessons. I had a lot of parents talking to me saying, please, when can they go back to school? It was incredible. And of course, the most important thing is that planning is absolutely essential, so that we have systems in place to cope with our education systems if and when we have another pandemic.
Yeah. We might just leave it there. We had a couple of other questions, but given the later start, we might hand it over to you, the audience. I'm sure someone else might want to make a comment at some stage. But if people in the audience have some questions for one or all of the panel members, please just put your hand up and we'll get a mic to you.
Viv, the thing that struck me the most, I think, was what you said. I mean, the problems around pandemic, there, and there's so much experience and giftedness to deal with it. But the problem that I heard you saying was that a lot of people today are disconnecting with their other fellow human beings. My question is, do you have any suggestions on what would help them to change that attitude and reconnect?
I think that there's an inherent selfishness in some people, as we've seen the best and the worst of humanity during the COVID, through the pandemic, where we've got people that are saying it's a conspiracy, I've been abused for wearing a mask, you know, all those kind of things. I've been abused because I've tried to keep people safe. I've been abused because I've followed the government requirements in aged care around vaccinations and all of those kind of things. So there's this, you know, people think it's their right to just be obnoxious, and then there's this flow on of people have become disconnected because of the pandemic, and then it's now perpetuated in the new way of workforce and how you get jobs and what you could ask for doing that job. Now, I think the very basics of how you get people connected again is encouraging people to speak to their neighbours, to hang over the back fence or the front gate or whatever it is, say hello to your postman. Just connecting in very little ways, and that adds up. I mean, the number of older people that are isolated in particular at home, that's why I said, you know, a barista can make such a difference to an older person or a person with a disability or just an ordinary person that just wants a coffee in that greeting to just connect, and it's, you know, it's letting your hearts loose. You know, we didn't need newspapers a long time ago because we had the back fence. You know, we could talk to people, we knew how to connect, and it's, as elders in our community, all of us and as experienced people, we need to model that, we need to promote that, we need to promote it with kids. I've got people now got a disability service, First Chance, with disabled children up to 5 years old, I think, are coming to Maroba to spend time with our residents with dementia. And it's just, the first outing was just magnificent. But one woman said, Viv, I went to an ordinary play group, and now all the women, she happened to mention what she was doing with Maroba, and now all the women at that saying, how can I get a gig there? I want to connect with older people. I want my kids to connect with older people. So there's this undercurrent movement of people that really want to connect with where it matters, with the wisdom of our society, with older people. And we need to promote that, we need to encourage it, we need to model it. You know, if you're an older person, and only a couple of you are here, I can see, but if you are, model generosity of your time and your voice. Model it. Be that generous, happy, open, older person that encourages younger people to connect with you, because what you're doing is you are downloading something they need in that. And our society cannot progress, its humanity, without your contribution. So you be the role models for that. I'm making my best efforts to be a role model for that, and I encourage every one of you to, because that is how we can change it, sir.
Yesterday on a group chat on WhatsApp, there was a post, and it's only a small group, a meditation group actually, Craig, and somebody who doesn't even go anymore, and it was just this big YouTube. Go to YouTube and you will find that they are tricking us about even the side effects of vaccination aren't being put out there. Have you seen this? This is sticks with people's, and it was so convincing. It actually got me in, card carrying, public health. So I guess we could put in the disinformation. So is that part, is that also part of it? You said about the vaccination, people are a bit weary. So I just didn't know what to do with it, Obviously I didn't repeat it, I didn't send it to people. but they're very clever. You know, so there's two questions. Is there any evidence there that, you know, they're hiding the TGA and the blah blahs, are hiding the side effects of vaccination, that children are dying from it and, you know, whatever. But also, what's happening? What's your thoughts about what's happening there?
Yeah, thanks. Look, no, there's no one's hiding anything. I work with people who do, you know, the raw surveillance and, you know, email, SMS people after they've had the shots and follow them up, and we're not seeing dangerous signals at all. And it's very clear that while there are adverse effects with some of the vaccines, the effect of COVID vastly outweighs it. So that's very clear, you know. And I don't reckon I'm considered moderate in my views on vaccination in the public health area. You know, I'm not a super pro. There's some I don't get. But there's some that are wonderful and I do get. You know, so. What can we do? I remember going back, I was doing a cholera outbreak in 1994 in Gaza Strip, and what we had to do then to inform the community about the value of hand washing and clean water was to go to the mosques and get the mullahs to speak about it, and to go to the schools and teach the kids, because the kids would teach, you know, quite smugly sometimes their parents. And I think a group of us thought back in about April of 2020, with these new vaccines coming on, we needed a vaccinology, you know, a vaccine immunology course being taught to, you know, 10, 12, 14-year-olds at school and all of high school. So they really understood, and they would understand what an mRNA vaccine is and could talk about it, and they weren't fearful. And this might sound very flat earthish, but I often thought, should we be teaching vaccinology rather than astronomy? You know, I mean, astronomy is important, I'm sure, but vaccinology, people need to know that how vaccines work, so they're not fearful. So I think that's something we probably should have invested in 2020. Try to head it off at the pass. You've got to go very, very early though, because once the groundswell comes of anti-vaccination, it's really hard to stop. So that's what I think we should have done.
Can I just comment a little bit on that? I think that disinformation is like age old. It's just the way that it's shared is different. So it's still up to the individual to decide what they think about it. And, you know, I guess in general practice, people come in all the time and say, look, I've been on the internet. Like, they're embarrassed about it. Go, no, that's great. What did you find on the internet, you know? And then you can talk about something. Unfortunately, people often put a symptom into the internet, you know, and then they think they've got leukemia, but actually they've probably got a cold. So it does take a person of some kind to try and kind of work out what the difference is. But I don't know if the disinformation is new. I think that's really old. But it doesn't help when you have someone like Donald Trump saying to use bleach and inject it intravenously.
It's a shame he didn't inject it.
On that theme, one thing which is really unhelpful is having politicians trying to put forward science, because then it becomes politics. And I think premiers, prime ministers probably should not have gone there. And I'll stop there.
Yeah. You know, talking way back in the pandemic early on, there was this hapless GP in Melbourne who I think was a really dedicated GP. Do you remember this story about this fellow who came back from America? Yeah. And he had a bit of a runny nose, I think, hardly any symptoms at all, and saw some people. And actually at that time, in the beginning, we were being advised only to test people from certain countries, and we mustn't test, actually weren't allowed to test anybody else. It was a public health. There were rules about what we could and couldn't do and what we had to do. So he actually went against the rules and tested himself just in case, and then ended up being COVID positive after having worked for I think about 2 days or something like that. And he was hung out to dry basically, you know. Do you remember that? You know, by politicians. So there you go, you know, politicisation of health. It's a problem.
Fiona talked about the difficulty of seeing a specialist in rural towns and stuff, but I think that's across the board, not only in regional areas but in our cities as well. Public health, if you need a joint replacement, it's at least 2 years. Childhood ENT, up to 5 years before you get seen. Is there all these elective surgeries that were put off during the pandemic are only adding to the waiting lists that we already had? Is there a plan at any level of government to deal with the backlog as well as the current caseload, I guess, of you know, needed health?
That's interesting. I think the best way to look at this is to analyze what happened in the interaction between public and private funding when the pandemic hit. At that point in time, the decision was made to have private insurers fundamentally sit on the bench, bank in, no use. Everybody knows here in the healthcare system that, you know, elective services that you can do in the private sector, if the doctor thinks, you know, that you have a private insurance or whatnot. That created certainly a backlog, and this is in every healthcare system in the world. They are catching up heavily. And this is, you're talking specifically about joint replacements, but similar types of elective care. You know, waiting times are not just gonna disappear, overnight. This is called a cohort effect. You know, there are not gonna be new cases. They're gonna pile up. So you just gotta increase activity. Now, to increase activity, you need infrastructure. You need doctors. So it's not very difficult, this equation. You need to build it. You need to fund it, and you need to actually resource it, both from a human side, you need the doctors, the nurses, the technology, and so on, and also the physical side. Now, go back to what I said in the beginning. The private insurers, the private sector was given, the private hospitals, given, let's say, for a period of time to the public system for the COVID emergency. Whether it was used or not, to the capacity it needed to be, we virtually didn't have that much COVID, you could argue. So a lot could have been done, but forget about that element. But a lot of that capital that was cashed in the private sector, really, it stayed there. There is a bit of a discussion about return to of premiums to private health insured individuals. And you might have heard that in the media, that you're going to get a little bit of a discount or the premiums are not going to rise. But, you know, like in many other sectors, the pandemic have benefited many industries. Private health insurance is one of them. Now, if you were potentially a radical, I'm making a self-joke perhaps, but at least an imaginative politician, you could say, what is the best use, given that you need resources of the 9 billion Australian dollars that every year taxpayers give to private health insurance? What is that best use? What use can you make of that to address exactly that problem, which is waiting times? My answer to that are two. You give it to the public sector. Okay, that's very good. We hire doctors, but are the doctors or nurses? Then the question is, are the doctors and nurses happy with that idea? That means competition. That means more doctors, more nurses. That means also prices going down. So that hasn't happened also because of that. The other option is that you actually get private insurers do what they do in other countries, in Holland, in Switzerland, in Israel, even in Colombia. What do? They insure for everything, all the costs. No unknown gap that when you get out of a hospital after whatever procedure, you found out that you actually went to the Maldives for a procedure, if you know what I mean, right? So your bill is actually twice as it was supposed to be. Now, this is a fundamental question because insurers are not even covering all the healthcare costs. So you buy a product that it's basically fundamentally disabling or not providing what you need. But these are the two options. It's not rocket science. You strengthen the public system, you put more workforce, you build more things, you make it work and more rapidly. That's what the NHS has been doing. In some regions, in Italy, in Spain, even in the UK, successfully, in other not. And that's, again, because of the global scarcity of workforce. You know, doctors don't grow overnight or over trees or under mysterious places. The other is that you actually use what you have, which is the private sector, which is now, and in fact, many insurers are called banks. They are banks, you know. So that's a big question we need to answer.
I think we might wrap it up there, if that's all right. I'm going to hand over to Rob. I've been sin bin for thank yous after my emotional response at the early childhood education last year. So I'll hand it over to Rob. Otherwise, I'll get emotional again thanking these people.
Well, thank you so much for such a thoughtful and instructive conversation. The problems are wicked problems, as they say. But I wonder, would you join me, please, and thank Helen, Fiona, Viv, Craig and Francesco for their time and sharing their wisdom, experience and wise counsel. Next month's topic is something which may resonate with some of the things that have actually been said here tonight. Our guest next month on April 19th is Tim Costello. Some of you may know Tim. He was originally a lawyer in both public and private practice. He then became the Mayor of St Kilda in Melbourne. Became famous because of his clashes with the then Premier of Victoria, Jeff Kennett. Subsequently, he became the CEO of World Vision, concerned with the most vulnerable and the less fortunate, not just in our community, but across the world, across the planet. And Tim's chosen topic, I'm sorry, Francesco, but he chose the topic, we live in a community, not an economy. So if you would come here next April 19 here, Tim Costello will be here to speak and share his experience and wisdom with us. So thank you so much. I appreciate you coming and we look forward to seeing you next time. Thank you.